So everybody, thank you and welcome to the second virtual tumor board of the Asia Pacific Geriatric Oncology Society. And today our hosts and presenters are from Kochi, Dr. Varun Raj and Dr. Jino Joy. And I must congratulate them because uh, the first fellowship in geriatric oncology on behalf of AGOS is at their center. So thank you very much. And I'm sure that we will be doing a lot of academic activities as we proceed further. I would also like to share with you my thoughts about what we learned from the tumor board that happened last month. Okay. Dr. Tilak and his team presented two cases, and there was very good discussion. So the first thing that I learned is that the people, the oncologists in India can be divided into two categories. One is those who assume that the older patient is fit and plan the treatment accordingly. And the other category is those who assume that the elderly patient is not fit and then, shift to palliative care. And the worrying part is that this is based on assumption. There is no real attempt at a systematic evaluation of the older person before taking this decision. So that was the first thing. And this was also evident in the two cases that were actually presented because when asked for a detailed scoring of the patients, in one case they were not able to provide that. So even in the case that was being presented, they had not done. Also, the third point that I wanted to share was that technological advances are important and especially important in the geriatric age group. And the discussion last time was on radiotherapy technique for a person with an abdominal disease and the use of artificial intelligence. So I was worried or wondering whether this is AI washing or there is really actual benefit. And Akhil Kapoor was nicely able to point out that there are 5 options created for the treatment planning of the day. And because it is in the abdominal cavity, based on the colonic content and the position of the colon, one of those 5 are selected by the artificial intelligence program as to what is most appropriate for that person for that day. And I think something like this is absolutely essential when we deal with geriatric patients, especially because they will have reduced body reserve and comorbidities and polypharmacy. So anything that we can, handle in that manner is exceedingly important. So with these introductory remarks, if Prem is here, I hand over to Prem. Otherwise, Dr. Varun Raj and Dr. Jino Joy can begin with their part of the presentations and moderation. Over to you, sir. On your screen, you can also see the esteemed expert panelists who are here with us today. And Dr. Adhikari, I'm sorry, Dr. Gopinath, Dr. Krishnakumar Rathnam, Dr. K. Pavithran, Dr. Sasidharan, Dr. Rakesh Mishra, Dr. M V Chandrakanth, and Dr. Syam Vikram. So with that word, Varun, I hand it over to you.
Sure. And thank you for the kind words, sir. And so I shall share my slides. Is it visible now?
Yes, sir.
Yes, we can see it.
All right. So today, yeah, it is the second tumor board of AGOS, and thank you, Parvish sir for being there as the mentor and who is the cornerstone of AGOS. And so this session include two cases. the one is a lady with Hodgkin lymphoma, and the second one is an elderly man with rectal cancer. So I will start with the first one. So I welcome all the panelists on board. Hope everyone joined. So our patient is a 76-year-old lady with a ECOG PS of 3 with lot of comorbidities like CAD, DM, and hypertension. And she actually initially presented to our pulmonology department with the post-COVID issues. It was way back in 2022, immediately after the COVID-19 wave. So she admitted with an LRTA under the pulmonary department. And also they also noticed that she had history of frequent falls, and a geriatric consultation was done at that time. So a routine assessment by our geriatric team, it showed that they identified the anemia, weight loss, and inguinal lymphadenopathy. So I'm showing only the relevant investigation. She had anemia, her albumin was just okay, the creatinine was normal, LDH was bit elevated, her ejection fraction was okay, and her BSA was 1.43, and they did an excision biopsy of the lymph node. Yeah, exactly, inguinal lymph node. It showed features of lymphoma, and IHC was done. It was consistent with the classical Hodgkin lymphoma lymphocyte depleted type. We know actually the lymphocyte depleted type is a rare one. It is more common in elderly and immunocompromised individuals, and it is having a poor prognosis when compared to the other subtypes. So subsequently, an all-body PET-CT was also done. It showed extensive the lymphadenopathy, both the supradiaphragmatic and infradiaphragmatic involvement. So it's a case of classical Hodgkin lymphoma, lymphocyte depleted type, and stage 3B. So the oncological diagnosis here is again a lymphocyte depleted classical Hodgkin lymphoma, stage 3B. She's an older adult with an age of 76 years. ECOG PS is 3, and her CARP score is 14 with a high risk of the chemotherapy related toxicity. That is, the chance of grade 3 toxicity is more than 83%. So my question is to my oncology friends. So here we have a patient who is elderly, frail, but with a curable malignancy. The chance of toxicity is very high with the chemotherapy. So how do you approach this situation? I'm not asking about which chemo you will give, but how to proceed with these findings. So I would like to ask this question to Dr. KK. Yes, Dr. Krishnakumar.
So thank you, Varun, for that case. So more often we are actually seeing these patients nowadays. I don't know whether there is a referral bias. Earlier they used to consider people incurable because of age, like what Purvish Parikh sir mentioned. So we've had a cluster of elderly Hodgkin, and not only Hodgkin, many of the elderly, and then we are hanging between cure versus toxicity. So now coming to your patient, this is a CAR TT score of high risk, and because there is the score is 14. Very recently, we have started showing interest, and we are trying to open a geriatric oncology clinic, which can be the gateway to assessment of patients. So this patient, I just want to, the basic principle will be, I think still we have to look at cure, Varun. We know that this is a high-risk disease in a high-risk patient. So we have two odds against her. She's a lymphocyte depleted. She has B symptoms, stage 3. So all the prognostic scoring is against us. But how is the, I know that, nowadays I think we've been trained to do a score on these patients to see what is the cardiac morbidity. She's a diabetic and hypertensive. So are these things under control, and is the cardiac okay? Cardiac function?
Everything is under control. The cardiac function is also under control.
Yeah, so she doesn't have any obvious CAD sitting against us, right?
Stable disease. Yeah.
Stable disease. So we can that is one saving grace. And the other point is, of course, you told that there is the risk of more than grade 3 toxicity is 83% as per the scoring. So whether we can go for we have to balance between going to lower intense regimen versus cure. That you said she was administered
I would like to ask actually can you tell me with or come up with actually one single step if a patient lands actually in your clinic, what will be the actually what will be
she
your
needs a
next
first she needs a CGA to be done. So
right.
what are her various domains? What is the functional domain, nutritional domain, and what is her frailty, and whether this patient, although is in our medical terms and as medical oncologists, we look only at the biology of the patient and the biology of the disease. We really don't go into the smaller, we should confess. Very recently, we have been looking at additional parameters like frailty. And so a CGA ideally to be done for this patient, a comprehensive geriatric assessment.
Previously, what we used to do that actually either to give the steroids only or some oral tablets. Now, I think the more actually the precise way or a prudent way is to do a CGA in such kind of patients. So, so Dr. Pavithran sir, so are you doing any screening tools in your practice? I'm not asking about this patient. Yeah, apart from that.
Yeah, in elderly, what we generally do is the screening tool like G8. That is one, because it is simple and it takes not much time compared to CGA, which may take 30 to 60 minutes, and it needs detailed evaluation. So simple thing may be a CGA score, and if required, we'll send to the geriatric screenings like that. Now, other thing is, we usually calculate the crash and CARG scores to predict what is the risk of chemotherapy toxicity. Then it is easy to discuss with the patient as well as the relatives regarding what is the risk, and so that we can decide about the chemotherapy options, whether to give intensive chemotherapy or just a low dose chemotherapy like that, based on the fitness of the patient, like whether fit patient or a frail patient. But ideally, even if the G8 is showing like high score, then there is an indication to do a full CGA score.
The entire CGA, right?
Yeah.
So, so the CGA in clinics, it's actually a difficult question. So I'd like to give this question to Dr. Chandrakanth. So are you able to do CGA in your clinics, yeah, in your practice, or it is being done by your geriatric friends? So how it is being done there?
Right, Dr. Varun, thanks for the question. So as as everybody is putting out, it's not easy to objectively assess whether this patient will tolerate chemotherapy. So we are trying to find out other surrogate objective ways to figure out whether this patient is going to tolerate chemo or not. So for that, first we need to understand what is his survival due to comorbidities itself. For example, if you have a comorbidity that is life threatening, then he would not qualify for anti-cancer therapy. So therefore, you would assess each domain, including the CGA. I mean, that is there in the CGA. So it's not practically possible to do a CGA in the clinic. It's time consuming. We try and look for other surrogates. For example, you were seeing the comorbidity index score or the frailty score. We try and do these, but I agree, we need to have a CGA and a geriatric assessment for this patient to objectively say whether he's going to tolerate and benefit from chemotherapy. It's not possible to do a CGA in an oncology clinic unless and until you have a proper geriatric assessment system in place.
Yeah, all right, Chandrakanth. If actually a proper CGA is not possible, Is it possible to do a practical GA as suggested by ASCO or Scope C, so which is, I think, validated in Indian patients also? So, what's your take about that?
There are online tools that are available. If I type the calculators, they open in the desktop, and I can keep numbering, and that will give you a rough estimate as to which way it goes.
And anyone among the panelists, are you following the PGA as suggested by ASCO or Scope C?
Not routinely.
Yeah. So my next question is to Dr. Krishnakumar. So it's actually a practical question. That is, do this course like CARG or CRASH,
We
is
are
it
using
realistic
CARG.
to influence your
CARG. We are using only CARG.
chemotherapy choices? Yeah. So is it realistically influence your chemotherapy choices, or will you go?
It does partly. So we are just in the transition from the so-called gut feeling, what comes to in our mind to treat, to reform ourselves into something little more objective. And see, many times the patient asks us, when you know that many of the patients with old age who are still willing for treatment, they are either related to doctors, and so sometimes they come and ask us what's the risk of toxicity, and sometimes we have to give them some obvious numbers. So we are using CARG since last year. We have just started using CARG score.
Okay.
Not CRASH, but CARG score, and then we use our clinical parameters, including the nutritional and other things.
All right. So as everyone in the panel suggested, actually, we also did the comprehensive CGA in this patient. So Dr. Jino, I think you can explain about this.
Good evening, everyone. So in this patient, in fact, prior to the diagnosis itself, we had the opportunity to evaluate the patient because, like Dr. Varun told us, the patient had actually was admitted with an LRTI post-COVID issues in pulmonary medicine, where we were evaluating her for recurrent falls. So we thought that we generally do a CGA whenever we are called for a consultation, and in that process, we found out that she has a type 2 diabetes mellitus, which was fairly controlled. She had hypertension. She was taking medications. We always do a brown bag examination, and we found that she had 5 medicines for her diabetes and hypertension, plus multiple supplements, because those days following COVID, everybody was, the tendency was to take more supplements. We found that she had not taken vaccinations. At that point, COVID vaccine also was not available. We found that her comorbidity indexes, the Charlson comorbidity index was 7 and CIRS-G was 19. We went into deeper geriatric assessments, where the functional assessments, we found that she was actually dependent in her mobility and transfers. She was actually requiring, because of her recurrent falls, she required to hold on to somebody to walk. She required support for her activities of daily living and IADLs as well, because she was always dependent on a caretaker. The tuck test which we did showed that she had taken 20 seconds to complete, with much difficulty when she was asked to walk alone. And we definitely considered she has a high fall risk. And moving on, our cognitive assessment actually showed that her MMSE was 24. Her geriatric depression scale was 11, indicative of clinical depression. And psychological depression was also assessed and found that she could be probably fitting into depression. However, what we found that she had an excellent social domain, stays with her son and family with adequate support. The family participation was very evident right from the beginning, and when we started working her up, and she was supported by good insurance and good resources otherwise. Nutritionally, the initial presentation itself was weight loss. So we found that she had a significant weight loss in the past 6 months. Nutrition assessment also showed that she had malnourishment. And her frailty assessment, we use a frail criteria, and she was fitting into a category of frail. When with the CFS score, she had 6, which was putting her as a moderately frail lady to begin with. So at the end of our CGA, we found that she has issues in multiple domains, and the issues which were identified included falls, frailty, depression, probably pseudo dementia at that point, insomnia, and malnourishment. So these were the syndromes identified in this lady, who was otherwise probably when we were taking discussions on her MDT on whether we should treat or not, these were the issues which we had in our hand. So again, my questions to my fellow geriatricians in this board, I would like to begin with Dr. Rakesh Mishra on these geriatric syndromes, mainly especially on this malnourishment, the depression, and the polypharmacy. Prior to the oncological treatment, how would you like to optimize and how do you want to generally take up the decisions on these issues, Dr. Rakesh?
Am I audible?
Yes.
Hi, thank you so much for this opportunity. Now, a very wonderful presentation and good approach. This is how we usually go about addressing an older person who has come to us prior to initiation of chemotherapy. Now, I'd like to take a moment to say that G8 screening tool that we were talking about, it's actually a screening tool which actually identifies the patients who warrant a more comprehensive geriatric assessment. So in case they score higher on the G8 screening tool, here the radiation therapy people refer these patients to us. We're actually currently having a study with them, which is using the VES13 as well as G8 screening tools for along with comprehensive geriatric assessment. Now, like Dr. Jino said, that polypharmacy was an issue here. Like this patient was on 5 different medications for her sugars. Definitely, when we do a comprehensive geriatric assessment, it also includes a detailed history and a thorough examination, and a brown bag check. And if we find that the patient is on more than 5 medications, it qualifies as polypharmacy. Now, definitely, if possible, we would like to give her higher doses of reach the maximal doses of one oral antihyperglycemic agent before introducing another. Then again, the causes of malnutrition in this patient, we have to see whether it is because of her depression itself, whether it is loss of appetite because of her malignancy, whether it is because of something like an edentulous state, which many of our older people have, or poor dentition, whether it is because of a lack of social support, or whether it is because of a combination of all these. So this is something which is usually picked up quite well if you do a thorough, comprehensive geriatric assessment. Uh, there are certain markers for malnutrition which we can use. For instance, this patient had an albumin of 3.4, and this patient also had a hemoglobin which was a little low, 9.4. Now, apart from, so we have to find out the cause for her anemia. Is it only because of malnutrition? Does she have any GI loss? Is it because of any vitamin deficiencies? So we would like to check her B12. We would like to check her iron stores. As regards depression, identifying depression in such a patient becomes a little difficult. So because she has scored so high on the geriatric depression scale, definitely she is having depression. Whether it only warrants psychotherapy or whether it also warrants pharmacological therapy, something which needs to be seen. Having said that, initiating antidepressants if your psychotherapy is not working would be helpful in helping her regain her appetite as well. Uh, the problem is all the antidepressants that we start, they usually take some time to act. So before initiating the chemotherapy, it might make sense that if warranted, we start the appropriate antidepressants as well.
Thank you, Dr. Rakesh. So, Dr. Rakesh, you could continue on answering the questions. What you would think about the frailty factor in this patient? We found that the patient is very frail. So, what are the interventions you would think that is impactful in reversing the frailty or modifying the risk before or during the treatment?
So there are a few interventions, like if in a CGA we identify the patient has malnutrition, we do a mini nutritional assessment and we find that the patient has or is at risk of malnutrition. Definitely making the meals more palatable, making the meals, if it's an edentulous patient, making it more suitable for her. In case you need to increase the protein or the calories, work in tandem with dietary to help modify the meals, making them high calorie and high protein. Look at the sugars and see whether you need to give a diabetic diet or not. This goes a long way. Nutrition goes a long way in addressing frailty. Apart from that, certain exercises, whatever the patient can tolerate, can be prescribed based on the patient's functional status.
Thank you. I think I'll put this question to Dr. Divyamol. So, Dr. Divya, I think everybody is worried about how to screen in busy clinics. So, I'm sure in all the discussions we had in the latest meeting which we had in Kochi, also we had a lot of debate how to screen this very fast. So, a CGA comes quite fast for a geriatrician, but then it comes with practice probably. So, any practical tips, or how do you tell us, how can we handle a CGA in a very busy clinic?
Um, Thank you, Jino, for this opportunity. For basically, in many of the screening that we do in CGA involves basic questioning about how their routine day-to-day lives is going about. So we can ask them regarding if it is the malnutrition. We can ask them regarding how many meals they have during the day. We can ask them what is there in their meal, meaning do they have rice alone? Sometimes when elderly leave alone, they have just rice and maybe one curry with them. So is it a balanced diet? We can explore through just that one question. What all do you have during the day? And also we can ask, have their appetite come down recently? That itself will give you an idea of whether the patient is eating well. Regarding depression, we can ask two questionnaires are also there. Simple questions regarding have you been feeling low lately? Simple questions itself can screen most of the items that we do in a CGA, and which can actually hint us on what to dig in deeper.
Yeah, I think that's what the consensus which we reached last time when we had the discussion on geriatric oncology in Cochin under AGOS, that we all have kind of modified our CGAs. We have tailor-made CGAs to fit into our busy clinics, and we had shared a couple of our models last time, the Amrita model and the medical trust model, as well as the CMC Vellore model. So what we all have done is we have tailor-made into asking very significant questions and identifying things as we go on, so that the CG actually can be done in a much shorter time, but touching on most of the factors. So I think we'll move on with the case. So we had, as our team had decided to give the clearance for the patient, and oncological treatment was undertaken and initiated by Dr. Varun and team. Also, our side, we thought we definitely need to treat the depression apart from the psychotherapy part. So we initiated mirtazapine. We chose mirtazapine because we thought it will also boost her appetite. We taught her sleep hygiene measures, nutritional rehabilitation and diet supplements were started. Our occupational therapy, physiotherapy team both started working on her because her mobility issues, her recurrent falls. We provided her walking aids, made her walk independently. We gave her vaccines in between. Influenza, pneumonia, and herpes zoster were considered from our side, and the government had issued COVID also subsequently to her. We ensured adequate diabetes and hypertension control were done with minimal medicines and insulin, and we took care of her polypharmacy. We reduced her overall medicines to just 5 medicines, and that's how we supported the journey in the oncology part with Dr. Varun. Yeah.
The Jino mentioned, actually, we are decided to proceed with the treatment of Hodgkin lymphoma in this elderly lady. As everybody knows, the Hodgkin and the myeloma, these all are the favorite topics for all madams. So we don't want to leave that disease, so we actually decided to treat it. So the issues to address here is that here we have an elderly lady who is frail, and we identified a lot of geriatric syndromes. So what about the use of anthracyclines in frail patient? So how would you approach this case, Dr. Chandrakanth? Yes, Chandrakanth.
Right. So, well, again, it's tricky to assess for anthracycline. In fact, for any chemotherapy fitness, again, we should go back to the same CGA, functional status, cognition, and the frailty score. If all things are fine, then the cumulative dose of anthra in Hodgkin's is not much. So we would have a cardiac assessment. In fact, we can do a GLS and a 3D echo, and we can have a baseline cardiac biomarkers in the hand. So if by the CGA this patient is fit for anthracycline, then we can actually use anthracycline, and we have used dexrazoxane in some of our patients. So if you can use dexrazoxane, it's not that
Prophylactic
expensive.
measure. Yeah, as
You
a
can,
prophylactic measure.
yeah, as a prophylactic measure, you can use it in these patients, and maybe you can prolong the infusion time of anthra. So maybe these are some ways to be a little cautious. Of course, we need to have a proper IV line in these patients, because a PICC is important because they're frail and extravasation is common. So I think the CGA plus specifically assessing the cardiac status, the liver function, renal function, I think these are more important. We find the cumulative dose is not much. I think that's the way to go. We can use some protective agents like dexrazoxane. Yeah.
Yeah, all are valid points, Chandrakanth. So, and so Pavithran sir, actually, is there any cutoff for the use of bleo in elderly? Because we all are actually scared to use bleo in elderly because of the risk of pulmonary fibrosis, which is irreversible. So, is there any cutoff? What about your practice in elderly patients?
Yeah, actually, bleomycin is an important drug in the treatment of Hodgkin's disease. But the issues are that what we are worried is about the lung toxicity. And
Yes.
this lung toxicity increases as the age advances, because if in the patient above 70, risk of bleomycin toxicity is more than 25%. Like that, if the renal function is low, that is increased creatinine, or previous COPD or some lung disease, then smoking history, all this increases the risk of bleomycin toxicity. So if such risk factors are there, better to avoid. Otherwise, you can use it, but again, it depends on the number of cycles used. So if you use 4 cycles of ABBD versus 2 cycles, or 2 cycles of ABD and 2 cycles of ABBD, the risk of toxicity is almost same, ABD versus 2 cycles of ABBD. So in a very fit patient, maybe you can use above 60, maybe you can maximum maybe 2 cycles, not more than that, because as the dose increases, the risk of toxicity also increases.
Yes, sir. And now we have actually the better molecules,
Yeah,
and we can
there are other
avoid.
agents like
Yeah. So Krishnakumar sir, so what about your take on the use of brentuximab or immune checkpoint inhibitors? Actually, at that time when I treated this patient, the Niva was not approved as first line. Only brentuximab was approved. So how you will approach this case if you omit bleo?
So AVD, there have been few patients for whom AVD backbone we have given, assuming that the echo with the GLS scoring is normal. There have been some rare patients where we've even gone up to the extent to see the LV function properly to make sure that there is no even subtle cardiac dysfunction, because as Pavithran sir mentioned, just like bleomycin has the cumulative dose, even if it has not reached a particular level, patients tend to have so baseline biomarkers in some patients who have real high risk. And when we do the actually very recently, I can't tell you about our experience. We've just started incorporating slowly into the geriatric oncology assessment, which is the CGA, as well as we are doing for patients with very high risk, we do baseline biomarkers. Now, I know that this is not the standard of care. We tried adopting it from the ESA recommendation, the first guidelines which came on Asian, on the geriatric oncology guidelines for managing various toxicities, cardio-oncology. So they say that actually it's a 2-year recommendation. We can do baseline troponin, and so some of the patients who are very high risk, we even follow up with serial troponin. If there is a sudden rise, then we stop. So we have done it for one patient, but now that is for the anthra. Then coming to avoiding bleo, definitely yes. I would be scared even with 1 or 2 doses of bleo, so very apprehensive. I don't use bleomycin. I have AVD as my backbone. Given a choice, it would be Nivo first in today's context, followed by BV. Hopefully, post-COVID, there is no lung ILD issues or other problems. Then Nivo would be my choice to go. Otherwise, we can go for a BV with AVD. And now you have that split dosing also available sometimes in elderly and frail, where you can just give 2 BVs and then follow it up with 4 AVD and then again to give 2 BV later and keep under follow-up. So that is also there. So it's highly tailored to the patient depending on the comorbidity assessment.
All right. Well said, sir. Yeah. So in this patient, actually, I have discussed the option of BV plus AVD to the patient, but actually, I have treated with a prepace of steroids, which is followed by AVD alone, mainly due to the financial reasons. The main toxicity occurred was the grade 3 febrile neutropenia after the first cycles and also grade 2 fatigue, but everything was managed with the supportive care measures. So treatment completed with the AVD into 6, and the end of treatment PET showed a complete response. And the end of treatment, the ECOG PS became 1. At the onset, it was 3, and at the end of treatment, it was actually it became 1. And also, we evaluated the end of treatment CGA also as a dynamic measure. So you can see actually the patient actually improved the all aspects of CGA, the functional variables, the cognitive, the memory, nutrition, and actually almost all the geriatric syndromes were not concerning her at that point when patient achieved remission. So it is about the treatment of that patient. So she was kept on follow-up after that. Then she relapsed exactly after 2 years. That is in November 2024. So she presented with the fever, anemia, and cough. And again, she developed the anemia. So the PET scan showed mainly disease in the mediastinum and abdominal lymph nodes. You can see the PET images, mainly in the lymph node limited disease. So actually surprisingly at that point, actually her the performance status was preserved. She was still ECOG PS1, and also CGA wise also she's actually fit for the further chemotherapy. So at the time of relapse, actually I have treated I have used brentuximab for this patient. I have treated with the brentuximab plus bendamustine for 3 cycles, and she achieved almost complete response after 3 cycles. So I omitted the bendamustine. Then I completed the 6 cycles with the brentuximab alone, and the end of treatment PET after 6 cycles showed a complete response. So now the patient is on BV maintenance. So the points to consider here. So it's an open question to all panelists. So my fellow, the oncologists and geriatricians and AGOS surgeon, everyone actually can contribute. So what is the role of dynamic CGA in our practice, even though it is not the standard practice? So I think you can actually you can put forward your views one by one. And Pavithran sir, so
yeah, dynamic CGA is important because the CGA can vary, because like in this patient, initially she was in a very poor condition, but after chemotherapy, she improved to the normal stage. So assessment in between during the treatment as well as initially during treatment as well as end of the treatment is important.
So is the Prabha madam joined?
Yeah. Actually, I would go by her pre-morbid history, how she was before she developed the malignancy. So if she were to be fit, like by history, if you can know that she was a fit person, even though PGA shows that there is decline in everything, and if it is due to the disease, I'm sure like treatment of the disease will put her back to normal. So if some elderly person was fit and exercising normally and cognitively fit prior to the onset of the malignancy, definitely she would be assessed as fit. Because during illness with which can make her nutritionally poor, which can decrease her functional status, and if it is attributed to the malignancy, I would say she should be treated.
All right.
Yeah.
Ma'am, actually,
So that's
if
why the
dynamic
CGA is important. Like suppose I have her CGA prior to the onset of malignancy. So I would know that she was fit and she's having all the geriatric syndromes mainly because of the malignancy itself. So it is important to go back in the history and see how she was also. In addition to doing the CGA at the point of care, that is before you start your chemotherapies.
all right, ma'am. Actually,
Yeah,
the
yeah.
main
Because
question is that if the dynamic CGA become the standard of care, actually, who
Yeah.
should treat it? Is it the oncologist or the geriatrician, or it should be a combined
Yeah,
approach?
actually, see,
Because we have
suppose
to
you
set
have
some time points, right?
Yeah, you have a follow-up, like you have a patient who has been under geriatrician, they will know. But if say the geriatrician sees for the first time, and like say many of the questions we ask about like how was she 6 months in the last 6 months, so that will tell us uh, her status. So somebody says, no, in the last 1 or 2 months only, she's not eating, she's losing weight, and then this malignancy was diagnosed. We know that 1 month or 2 months back, she was fit. So we can go back and ask the same CGA question. There is a 10-minute comprehensive geriatric assessment, which is there as a WHO toolkit for primary health centers. That is good enough for us. We use it in our day-to-day practice because that can
So
be
it's
done
a
in 10
10-minute
minutes.
CGA.
Yeah,
Oh,
and even a nurse, even my department attendant was doing it for us. And look at the components, like, okay, like her cognition is assessed just by 3-word recall. If she can recall at least 2 of the 3 words that you have told after some time, that means cognition is okay. Then comes depression. The question is, are you sad or depressed, and how long? Okay. So everybody will be sad after a diagnosis of malignancy for sure. That we will not assess as depression, because depression means it should be there with the patient for some time. Then the third question that we ask is about incontinence, and the fourth one that we ask is history of fall. So again, if the patient has been falling after patient developed malignancy, that means it is all due to malignancy. So we have to, of course, improve the nutritional condition, exercise, high protein diet. If she has sleep issues, that has to be addressed. So all that we do for a geriatric patient, we have to continue to be doing while the oncologists assess the patient for fitness for chemotherapy in their own way. That is based on the toxicities of the drug. So I was thinking that for cardiac assessment, even NitroPro-BNP is a very good biomarker, because if they have subclinical heart failure already, such a patient may go into overt heart failure after your anthracycline. So not only troponin, you can also do a NitroPro-BNP, because many of the patients do have a subclinical heart failure already, in which case just giving anthracycline can push them off balance. Because all these frail patients, they won't have exercised much. They would just maybe walk to the washroom and come back. But if they put on a challenge, they may develop overt heart failure. So NitroPro-BNP is a very good biomarker that can be used. Because if that is elevated, already we know that there is a possibility of the patient going into overt heart failure. So that is also a good biomarker that we can use. If it's very high, you know this is not the patient for you. But if it is just normal or just outside the reference range, it's okay. We can still take the patient and give the patient, of course, dose. I know for a frail patient, you will adjust the dosage as well and then give the treatment. So if somebody has been really fit, like what we do in geriatrics is somebody who's been exercising regularly, okay, for maybe many years, 10 years, we assess their age as 10 years less. Whereas somebody who has been not exercising at all, mobility is restricted for a long time, such a patient is really frail, and even if they are 60, probably we would put them as 70, like that. So all that matters. The fitness that they had before they developed cancer is what matters a lot. In addition to doing CGA at the point, and then serially as we go through the chemotherapy, and suppose the patient is becoming frail with chemotherapy, we know, like, we have to stop, watch, see what has happened. But if the patient is improving and improving, and what you did was absolutely right, you gave steroids first, with which many of these frailty markers will improve. There will be a significant improvement with the steroid that you give. Then the patient becomes fit, patient will eat better, nutritionally better, mobilize better, and then you have given chemo. I feel that's the right approach, I would say.
Yeah, thank you for the valuable points.
Yeah.
Yeah, the next question, actually, this question is more or like a which comes first, the chicken or the egg? That is, yeah, in this patient, the patient CGA improved the after treatment. So, do you see this as evidence that treating cancer reverses frailty, or the interventions by the geriatrician enhance cancer outcome? So Chandrakanth, what's your take about that? Or Dr. Rakesh also can answer that.
Yeah. What was the question, Varun?
Yeah. In this patient, the patient's CGA improved. Actually, it was a dramatic improvement after treatment. So, do you
Right.
see this as an evidence that treating cancer it reverses frailty, or the geriatric intervention enhance cancer outcome?
Right.
Or
So yeah, so CGA is important to plan the initial treatment, and in this situation, what is the response to treatment? This also a CGA can guide us. So if the CGA is worsening, then probably your initial selection of chemotherapeutic regimen is not good, or the disease is bad. Then you need to probably change the plan. If there is an improvement in the CGA score, then probably you can add a better chemotherapy regimen. That's a good sign. Yeah. Supposing, let's say, I didn't give chemotherapy, I just gave prednisolone for this patient, and the patient's CG has improved over a period of time, then I would go ahead and add an anthracycline-based chemo. So CGA is dynamic. The problem with static CGA is it's only a single time assessment, but this keeps changing. So if there is an improvement in CGA score, that means the treatment is working, the disease is becoming better. We can actually escalate onto the treatment.
right. Yeah, nice. So let's move on to the next slide. So the key takeaways from this case is the CGA is both diagnostic and prognostic. Frailty and all other syndromes, that is geriatric syndromes, were as significant as malignancy in an elderly patient. So holistic intervention improved resilience because remission was accompanied by actually the reversal of frailty, malnutrition, and depression in our patient. So at the end of the initial actually at the end of the treatment, then relapse, the patient was more fitter, more independent, and psychologically stronger. So it actually demonstrates the long-term benefit of integrated geriatric interventions. So I think so after this case, I think we can move on to the second case. It's a totally different case when compared to the first one. So Dr. Jino, you can summarize the case.
This is, due to the lack of time, we'll run through the case. This is an 86-year-old widower with 2 children, is a farmer by profession. He came to the OPD with bleeding PR and constipation, which he reported over the last 3 weeks. No similar illness. He has systemic hypertension. During the initial evaluation, he did not know what medicines he was taking, but he just told that he's taking 1 tablet for that. He was on once daily use of a Zeroflow inhaler. No family history of any malignancy or genetic disorders. Baseline examinations revealed nothing significant. Vital examination was normal. On a local examination, we found that on the PR examination, we found that we could feel a mass, protruding, and systemic examination otherwise was normal. The initial workup revealed pretty normal blood results. we went ahead with a colonoscopy, which revealed there was a lesion 5 centimeter from the anal verge, which was circumferential, and a biopsy was taken, which came out as a moderately differential adenoid carcinoma. Now, MRI pelvis was done for seeing the local spread. We found that the disease was locally advanced and staging was T4N1. A whole body PET was done to look for metastasis, and we could not find any distant mets except the local lymph node advanced spread. So as we could rush through the PET images, we could see the disease and the local nodal involvement. Now the CGA was done for the patient. As I mentioned, the medical side, we had only hypertension and OAD. We found that he has a bilateral cataract and some minor visual impairment, no major cardiac symptoms. Nocturia was bothering him. There were only two medications. One was, of course, the inhaler, and other was the antihypertensive medicine. He had taken COVID 2 doses provided by the government. Now, coming to the functional domain, this very elderly gentleman actually had full ADLs independent. He was still actively involved in farming, and he was independent and mobile. No falls. Tug was not documented properly, but he could do independently, and we assume that he would have had a very low tug score. Hand grip strength was done following in a very robust range. A cognitive domain, he had 3-word recall, which was normal, so we didn't proceed for a detailed MMSE. No cognitive impairment was otherwise told by the family. We did just a PHQ-2 questionnaire, no signs of depression. He was getting normal sleep, no anxiety, even related to the diagnosis which we had made. He did not have any anxiety. Good family support again in this case as well. We noticed that he had unintentional weight loss and mild loss of appetite, but still he was actually not having any signs of frailty in frailty assessment as well. So we couldn't identify much of geriatric syndromes. Constipation, LUTs, and loss of weight were found, and cataract was newly discovered. But it was none of these things were bothering him to a greater extent, apart from the presenting complaint of bleeding PR and constipation, which he came to the hospital. So overall, we had a very robust, functional, elderly gentleman who with a good social support, very low comorbidity scores, very low medication burden, and we thought he is a fit for multimodal therapy. Our initial evaluation after CGA was that he could be cleared for a surgery or chemotherapy, and we referred the patient back to Oncology MDT for further evaluation. So before we proceed to the oncological plan, so patient appeared very robust on our CGA evaluation. So we were wondering what could be the vulnerabilities which could be missed, what could be affecting our treatment tolerance, because at this conventional CGA we were planning to give him, or we in fact wrote that he is robust to take up the treatment. Is there any pitfall that we could have missed during our assessment? Could Dr. Rakesh throw some light on this?
So a comprehensive geriatric assessment, if it is comprehensive enough, usually is good enough to find all the problems that are associated with an older person who's heading for a chemotherapy. Having said that, a complete nutritional assessment is actually very important. Do we have any nutritional markers for him?
We have the hemoglobin and albumin, which were low. He didn't, in fact, even with the bleeding PR, he didn't have a anemia actually.
So his gait also you think was fine.
Yes.
His balance was okay.
Yeah.
Many a times we can pick up subclinical malnutrition with a full mini nutritional assessment. Then psych issues, a PHQ-2 may not be a good enough tool. You may have to do a full, you may have to use a PHQ, either a PHQ-9 or a geriatric depression scale to really find out whether this patient is dealing with depression, because many a times the older the older adults are not really forthcoming, especially the males are not very forthcoming with when you ask them direct questions regarding depression. So certain psychiatry issues, if they are there or may need to be addressed before starting the chemo, well and good. Then again, it's good that you have addressed or you have assessed him for the financial wherewithal to withstand the treatment. So I would also state that what Dr. Prabha ma'am said, that a good baseline, if he has a good baseline, as is evidenced in your history, tells you that he may be able to withstand the chemotherapy better than his peers, age matched peers.
Dr. Rakesh, again, are there any novel markers? Because everybody is interested in knowing about frailty markers, sarcopenia markers. Is there anything we could do to get away with CGA and probably predict? You were asking us albumin and hemoglobin.
Yes. Unfortunately, no single blood test can supplant a detailed clinical examination history as well as a detailed comprehensive geriatric assessment. Having said that, there are certain markers of inflammation like CRP, interleukin 6, which have been linked with systemic inflammation, which may even predict toxicity. But having said that, a lot of the times any intercurrent illness also causes these markers to go up. Then again, there are certain nutritional markers like albumin, hemoglobin, which can tell you that the patient may be at risk of a higher toxicity, and these malnutrition needs to be picked up and mitigated earlier. There are a lot of these scores that we use before starting chemotherapy, and a lot of these markers are parts of these scores. Like the crash score uses your creat clearance, your albumin, your hemoglobin. The CARC score again uses your hemoglobin and creatinine. So these are a few tests which can be used, but again, I would reiterate that none of these can supplant a detailed comprehensive geriatric assessment. So we are stuck with CGA.
Thank you. I think for now we don't have a shortcut. We have to go for the, and like all of you would have noticed, in this case we actually did a very quick CGA because over the time of practicing geriatric oncology in medical rest, that was one of our first cases, and that we had an MMSC, GDS, everything in detail. With the time issue becoming a real issue, we started making it shorter, and that's when we introduced actually the hand grip strength into quickly assessing frailty as well as the sarcopenia, which started giving us more information quickly. So over to Dr. Varun.
Yeah. So now we have actually a very elderly man who is fit, ECOG PS1, and our geriatrician cleared him for any form of treatment. That's either surgery or radiation or chemo. So now the ball is in our court. So it's a locally advanced disease, T4N1M0 disease, with an MRF involvement, that is the mesorectal fascia is involved. No geriatric syndromes. Patient is having a very good social support, no financial constraints. So it's a difficult situation. So how to approach? So I would like to hear from Pavithran sir in this case, because if we go by recommendation, we have to either treat him with the total neoadjuvant therapy TNT, or the conventional long course therapy followed with the reassessment and surgery. But still, is it practical in an 86-year-old man? So and also the CARC score for this patient is, so if you are using a single agent chemo, it is the low risk, and if you are using the combination chemo, it comes only the intermediate risk. So the CARG is also favoring for the use of chemo, but still in practice, so how you would approach this case?
Yeah, ideally, in locally advanced disease, you need total neoadjuvant treatment. That is chemotherapy followed by radiation, or radiation followed by chemotherapy, then surgery.
Yes.
But in this patient, given the age and above, the issue is the full dose chemotherapy you may not be able to give. Because above 70 and also above the age of 70 years, the benefit of oxaliplatin is also not that proven. And second thing is chemotoxicity, because it is associated with significant toxicity. If it is Folfhouse or Kappa's, about 18% of these patients, elderly, can develop significant neuropathy. So that may be a limiting factor. So ideal will be in this patient, even if you are giving chemotherapy, will be a single agent like 5-fluorouracil or maybe capecitabine. So that will definitely affect the benefit of the treatment.
So are you
Yeah.
favoring the long course therapy followed by surgery, or?
Yeah, other option is like chemotherapy, radiation, long course radiation followed by, if there is good response, wait and watch. But the recent SEER data shows that chemoradiation followed by surgery is the best option if it is possible, and if the patient is willing like that.
So, yeah, thank you. And Krishnakumar sir, how do you approach this case? Because here the finance is not an issue. Will you ask for an MSA in this patient?
Yeah, I was just about to ask you, because we don't do biomarkers in non-metastatic settings.
Yes.
So after the dostarlimab story, sometimes, you have the odd patient, if you get an MSI, and if it is very high, we can keep it in the back of our mind. But since you said that this patient is extremely fit, I probably will consider long course CTRT as the first modality, followed by if you have repeatedly told me the patient is robust, and for a single agent treatment toxicity score is not that much with CARG. Of course, with poly agent it is going to increase, but some dose adjusted, if you are able to push capox in this patient, or only capecitabine for another 6 more cycles. What if, and this is according to the ESMO definition, comes as the ugly disease with the T4 and N1. If he goes into a clinical CR, probably wait and watch. That is what most of our surgeons are doing here nowadays. Because at that point, it is not about the longevity or curing him and making him live longer, but it is more about the quality of life also. So he apparently seems to be a very functionally active guy, and you're going to treat him and put him on a colostomy, which probably will eventually occur. He will have to undergo abdominoperineal resection with a permanent colostomy. We don't know. At the end of the day, we may be curing him, probably, but we may be worsening his quality of life. So I think long course CTRT followed by only capecitabine as a shared decision making. If oxaliplatin also can be added, well and good. After clearly seeing his creatine values and looking at, we are very sure that he's not, his functions are good, and with close observation, we can go ahead and finish just a CTRT and chemo, and hoping that he gets into a clinical CYR.
Yeah, all are practical aspects. Thank you. And so actually, I think you already answered this question also, the use of doublet in elderly. So Dr. Chandrakanth, so what about the issue with CARG and GA cancers? You feel, is it insufficient in the case of GA cancers, or is it okay to use CARG in all GA cancers? Chandrakanth? Yeah, I think he's I think he's not available at present. So Krishnakumar sir, actually, can you take this question? The CARG and GA cancers, is there any issue here?
Yeah, actually, CARG, when it comes to GI cancers, I think CARG, I think the original studies haven't shown there is a bias. So there we would not be able, when it is GI, it automatically, the risk factor for both GI and GU increases actually.
Exactly.
And
Yeah.
CARG may not, definitely by seeing the treatment toxicity score, yeah, although when you're looking at the CARG TT calculation, you can see that when it's a GI or GU, it increases, it adds more points. But yeah, there is, it doesn't correlate actually.
Yes, sir. Because if you apply the CARG to GA cancers, it will automatically go to the intermediate or because in most of the GA cancers, we are using actually polychemotherapy. So it automatically will go to the intermediate or high risk. So it is actually more or less like an overestimation of the toxicity. So that is why now the TMH is coming up with a prospective trial that is called CARG GA. That is a special tool to assess the CARG actually toxicity in GA cancers. It's actually a prospective study. Medical Trust Hospital is also part of that trial. We are waiting for the ethical committee approval from TMH. So so now actually, it is the time for the surgeon to enter. So sorry, actually, Sham sir, for keeping you waiting for a long time. So let's see what is the surgeon's impact on elderly cancer outcomes. So the key points here is that, sir, actually, what are the challenges you see in a patient, in an elderly patient who needs rectal cancer surgery? Hello, Dr. Syam Vikram. Hello. He's still in the panel.
Sir, I think so Dr. Sham is facing some technical issues, sir.
Or is it? Okay. So the issues that I wanted to discuss here is mainly the issue of stoma and all. So let's see whether he can join or not. Hello, Dr. Sham. Hello.
Hello.
And hello, Dr. Sham. All right. And also about the incorporation of this geriatric assessment in the screening to the pre-anesthetic checkup. We all know that usually conventionally the surgeons are mainly using the PAC, that is mainly based on the organ function, PFT, echo, and the comorbidities. But whether we should include the geriatric domains also, particularly when we are dealing with an elderly cancer, because the postoperative cognitive decline and functional decline is really important to us. So then about the role of rehabilitation, it's actually a perioperative method to improve the functional outcome of the patient. And so here the objective is, we know in all oncological meetings, or in the main objective that we mainly hear or say in all the clinical trials is to improve the overall survival. But in a case of an elderly patient, it is the OS is not only the only objective, because we have to give the equal weightage to improve the functional outcome and also to preserve the cognitive status of the patient. So actually, I think let's stop this. These all are the topics I kept as a backup. I think we can discuss all these points in the upcoming AGOS conference at Bangalore. So this is our geriatric oncology team at our hospital, Medical Trust Hospital, and thank you all for the patience.
Thank you very much. I think this has been a very educative and informative session. I must congratulate Varun and Jino for really putting your heart to developing and discussing these two cases. And a lot of interaction did happen, especially about assessing the patients correctly. And some discussion did also occur on what is good to do and what is essential. So we need to distinguish between what is the bare minimum versus what else can be done in any particular patient. But hopefully the interactions will lead to a better treatment plan. One thing that I found missing was taking into consideration what is the priority from the patients and caregivers point of view.
Yes,
even
I was thinking of that.
So actually, in our both
Patient
patients,
preference is the most important here.
exactly. Actually, in our both patients, the social support was really good in our both cases. So both the patient and family wants treatment, and they all want to actually come back to their normal life. So that was the thing that pushed us forward.
right. So I'm glad that the social support was there. But my question was not related to whether to take treatment or not, but what is the goal that they want out of the treatment? And we just assume that the best chance of cure or the longest survival is the top priority. In many instances, small, not many, but at least 20-25% of patients have some other priority, like having a treatment schedule where the hospital visits are not very frequent because they are living 300 kilometers away, for instance, or they want best quality of life. If they have to compare to chance of cure versus quality of life, they prefer quality of life. So that sort of thing, I think, as we go ahead, more and more we will have to pay attention to what is the objective that the patient and caregivers want out of the treatment. So I
Because
will
you
stop
need
here.
to give a clear picture to the patient about the surgery and the morbidity with which she has to live with. That is very important, because sometimes what we have seen is with just radiotherapy, they undergo remission for 1 or 2 years, chemo radiation alone. We have had one patient here where I think he had remission for about 1 year. And again, he came, again, they gave a small dose of radiation. So he lived for another 6 months or so. So patient preference, I think, is very important. Like the patient says, I will go ahead with anything. And there may be a purpose for him to say that. So I fully agree with Purvish Parikh sir. Vast experience he has.
Thank you very much, everybody. I thank the panelists also for having such a insightful discussion. And before we sign off, we are already 15 minutes behind schedule. Before we sign off, I must remind everybody that next month again, same time, we hope to see you again.